Hello everyone. Today we shall have a quick session on Alopecia Areata. I'm Dr. Abraham from Hair and Dermatology Specialist. So this is a follow-up video to others that are also looking at hair loss. In this case, we are looking at one of the causes of non-scarring hair loss. So Alopecia Areata is one of the common conditions, and you realize that is one of the things that disturb people because all of a sudden someone loses hair on different patches on the scalp, and you find that some people even think that maybe they were visited by witch doctors who cut off their hair, meanwhile when they were sleeping. And that is the narrative that people have in the different societies. So as you can see in these pictures that I've displayed on the computer, so you find that this particular patient had a patch here of hair loss, another patch there. As you can see, the same arrangement here. And then as you can see here, this one also has patches of hair loss. Also, this is a white man's scalp having a similar condition. So it is not witchcraft, but rather a disease process. So alopecia areata is one of the causes of non-scarring patterns of hair loss, most commonly presented as circular areas of hair loss. So it has been thought that it is an autoimmune process that is driven by T cells, and it can lead to even total hair loss. And sometimes it can actually lead to loss of the hair on the entire body. That's the variant usually called alopecia universalis. And then if you call it totalis, if it's only the scalp, but the rest of the body is still having the hairs. So this word alopecia originated from the Greek term, also called alopecia, and actually this was derived from hair loss from the fox male. So these were little animals in a dog family that could actually manifest with hair loss, and the word was born from that process that occurs in animals to later on be given to humans and termed as alopecia areata. So as you can see in this picture, this is the fox male, and you find that it also has areas of hair loss, as you can see here. If I magnify for you, here the hair has gone, here the hair has gone, here the hair has gone, even around here the hair has gone. So it is similar to what we see in humans, but in this case, the causes are very, very much different. And this is a non-scarring type of alopecia, as I had mentioned, and it has been speculated to be associated with other autoimmune diseases, and plus a possibility of either genetic contribution or even environmental influences. So the genetic component contributes, there's about 55% concordance, that is in identical twins, suggesting that there may be a strong relationship with genetics and hereditary possibility for this particular condition called alopecia areata. And it is because of the genetic contribution that we now have environmental factors coming in to play a role. But all these theories have not yet been confirmed. And in the pathophysiology, we see that it is usually characterized by lymphocytic infiltrate around hair follicles, especially the CD8 cells. That is in the acute phase. But then later on, this affected hairs are actually able to regrow. That means that there's no effect on the stem cells located at the base of the hair follicles. And when you look at this particular condition, alopecia areata, it usually has a very chronic nature. Sometimes someone can get an episode this year, after it will resolve, and they get another one after like 2 years or after even 5 years. And it's for some people, they even suggest that there's no need for treatment. Others actually treat in order to prevent uh, the the cosmetic or the appearance that comes with patches of hair loss. And you find that when it comes to the epidemiology, in those better set countries where they are able to do these studies, the epidemiology, like in the United States of America, was found to be about 0.1 to 0.2%. And the lifetime risk of acquiring this condition, it stands at about 1.7%. And you find that 20% of the affected individuals, they have a positive family history of the condition. And this is actually more suggesting about the possibility of genetic influence or genetic contribution in the development of alopecia areata. So when you go to the pathogenesis, these are the hypothesized ways of how alopecia comes about. and these are all not proven. So there's a thinking that one, there's an environmental trigger, like either viral infection, a bacterial infection, a parasitic infection that occur in an individual who is actually genetically predisposed. And in this case, what is the thinking currently is that this is a T-cell driven autoimmune condition that results from a direct attack of the T cells on the hair follicles. And eventually, there's a thinking that, hair follicles are one of the sites that are immune privileged, meaning that they're not usually invaded by the immune cells. So there's a thinking that there's a loss of this privilege, what that makes the hair follicles susceptible to the attack from the T cells. And because of this, that's when you have now hair loss that can actually regrow after a short period of time. And the genetic susceptibility has been associated with progenic variation, including particular human leukocyte antigens and alleles, meaning that because we have different alleles of the human leukocyte antigens, so people with particular lines end up being at risk of developing alopecia areata. And there's also thinking that there's an association with other immunological mediators like the interleukin 2 plus its receptor, as well as interleukin 21 playing a role, as well as the CTLA4. So all these play a role in all contribute to the development of alopecia areata. Other things like the genes that are supposed to deal with the oxidative stress or that are supposed to deal with apoptosis, they may be also interfered with, but still all this is still theoretical and not yet confirmed. So when you look at the evidence that tries to suggest that this is an autoimmune condition, the first one is that when you take off lesional skin in alopecia areata, especially the acute lesions, you will find infiltration of lymphocytes, which are CD8 positive lymphocytes. And in this case, you know that the CD8 lymphocytes usually respond to antigens presented by major histocompatibility class 1. And that one usually is always presented in case a cell is either stressed, a cell is infected, or there's something wrong with a cell, or it has now become malignant. That's when it expresses the the major histocompatibility class 1. So, and this is what triggers the destruction of these cells at the base of the hair follicle. But this does not affect the stem cells. That's why the hairs are able to grow after you have stopped the inflammatory process. And experiments in mouse models confirmed that CD8 cells can induce alopecia when transferred to human skin grafts. So meaning that if you get these CD4 cells and then put them in a haired skin of a human, you'll find that you're able to induce alopecia, meaning that these cells can actually directly target the keratinocytes at the base of the hair follicle. Then there are particular key cytokines and pathways that have been thought to play a role in the development of this condition. And the first one includes the interferon alpha, and as well as other cytokines in the interleukin 2, interleukin 17, interleukin 15, interleukin 21. These are thought to activate the JAK-STAT pathway, and inhibitors like the JAK kinase inhibitors, including tofacitinib, the ruxolitinib, have been shown actually to promote hair growth, meaning that the JAK-STAT pathway may have a central role in the pathogenesis of alopecia areata. So this theory that these hair follicles actually lose the immune privilege, we thought that these hair follicles will usually be protected from effects of your immune system because of the location. The way you say that the central nervous system is immune privileged, the way you say but the bone marrow is immune privileged, even the hair follicles are immune privileged, meaning that they're not easily attacked by the immune system. So it is because of the loss of that privilege that the hair follicles end up being attacked. And you find that this privilege is usually because the cells in these areas don't express a lot of major histocompatibility class 1 molecules that are recognized by the CD8 plus cells that are supposed to attack any cell of the body that is either malfunctioning, that is stressed, that is infected. So this is what we are seeing here, that in areas where you're having alopecia areata, the cells there usually express a lot of MHC class 1 that is now recognized by the CD8, resulting into death of these cells. And that's how alopecia areata comes about. So when you go to the clinical picture, how do patients with alopecia areata present? So in this case, they'll have the typical form that we usually see, either round or ovoid patches of hair loss that is usually non-scarring. So when you examine the skin, it's going to be normal, a little bit soft, not even showing any signs of scarring. But then when you see the hairs, you see what we call the exclamation marks, or marks hairs that are populating the area of hair loss. And this is usually seen at the margins. And then we have different variants of how it can present. We have the one we call alopecia totalis. In that case, if you have complete loss of the hair on the scalp, that is what we call alopecia totalis. Then we call it alopecia universalis if all the hair covered areas of the body are affected. That means that someone will lose hair on the scalp, lose hair on the eyebrows, the beard area, the chest, the back, the pubic area, as well as even on the arms and the legs. Wherever the hair is, disappears. That's when it becomes alopecia universalis. Then we have omphiasis pattern. Now, omphiasis pattern, commonly, someone gets a band-like loss of hair, maybe around the head, like here, just above the ears, and there's a band of hair loss. That is the omphiasis type of hair loss or alopecia areata. Then some people can get a reticular variant. In this case, someone loses patchy hair here as this one is growing, then another patch drops just nearby, ending up with a reticulate pattern. And the other last variant is what we call the diffuse variant, where someone has just widespread thinning, possibly leading to rapid graying of the hairs, and only all the hairs almost everywhere, they become thin, and then most of them get lost. So remember, alopecia areata is one of the conditions that has been associated with other systemic conditions as well as nail involvement. So in alopecia areata, every time you make that diagnosis, you need to examine the nails of the patient, including both the toenails and the fingernails. And commonly, the common feature that we see is nail pitting, and this is one of the causes of the trachonicia. You know, trachonicia with the sandpaper-like appearance of the nails, which can either present being brittle nails or nycolisis, as well as chorionicia as the manifestations of nail involvement in alopecia areata. So now this one suggests for you that you need also to make sure that this patient doesn't have other conditions that can affect the nails, including nail lichen planus and nail psoriasis that can have similar features as we see here in alopecia areata. So every time you get a patient with 20 nail dystrophy, meaning that any disorder that involves all the 20 nails, alopecia areata is one of the differentials that you're supposed to think about. So when you go through these pictures, you'll find that I'm trying to show you in this area, the patient had hair loss, a patch there. In this case, the patient had almost the entire scalp having no hair. You see in the eyebrows don't have hair. So in this case, the patient had alopecia universalis. Then in this case, this is just a diffuse type where you just have general thinning of the hair with marked hair loss. And then this is the omphiasis type of hair loss that appears around the supraauricular area, just like a band of hair loss, as if someone is putting on, or as if it is a form of a haircut. Then you can also get alopecia areata affecting the beard area, and then here you have it affecting the nails. And now whether these nails look like even nail psoriasis and then nail lichen planus. So you have to make sure that you examine the patient fully to see if there are any other diseases that can be suggestive of other conditions. So when you look at the differentials, which other things you have to think about in case you made a diagnosis of alopecia areata, we have things like the tinea capitis, trichotillomania, that's psychiatric disorder where someone pulls up the hair, then tractional alopecia for women who plait hair, then secondary syphilis, but in secondary syphilis, the type of hair loss will be like moth-eaten type. like as if a moth has eaten the hairs. So that's how it will appear like in secondary syphilis. And then you can also have to think about the kerogen, effluvium, as one of your differential. So you have to do trichoscopy, and then in trichoscopy, we shall see the features of alopecia areata just in a minute. We have diseases that have been associated with alopecia areata, and it is key for you actually to identify if your patient with this type of hair loss has any other underlying either dermatological or systemic disease. So under dermatological, we can have things like atopy, which includes allergic rhinitis, which includes atopic dermatitis and asthma, and this has been seen in more than 40% of patients with alopecia areata. In other autoimmune thyroid diseases like the Hashimoto thyroiditis, vitiligo, inflammatory bowel disease, has also been associated with alopecia areata. Remember, all these are autoimmune conditions, just like alopecia areata. Then we can also have autoimmune polyendocrinopathy syndrome type 1, especially the autosomal recessive type, has also been associated with alopecia areata, as well as diabetes, especially type 1 diabetes, that we usually see in young patients. Then, when you look at the HLA association, alopecia areata has been associated with particular human leukocyte antigens, and these ones vary depending on the individual. So, people with HLA, the QB1 0301, that is the Q7, and HLA, the QB1 03, that is the Q3, HLA DRB1, that is 1104, that is the R11, have been associated with a higher risk of developing alopecia areata. So if you are able to do genetic testing or HLA testing in your setting, these are the human leukocyte antigens that you may be looking out for. And then other association has been with the function of the T regulatory cells, including other cytokines like interleukin 2, interleukin 21, and then other particular chemicals in the body. So all these should come into your mind when managing a patient with alopecia areata. So one of the key investigations that you have to do is trichoscopy. So under trichoscopy, remember we use either dermoscope to examine the hair and then see how the features or how is the hair looking like. And one of the key features of trichoscopy in alopecia areata is what we call the exclamation point hairs or the exclamation mark hairs. You know, an exclamation mark looks like this. So that one I've drawn, and then you see these hairs especially at the periphery of the lesion. So this is how they will look like. You see that, all those are exclamation mark hairs. Then you can see yellow dots, and these are empty follicles or keratin deposits. You know, like for example, the one you see here, that's a yellow dot, and even here, that's a yellow dot, and it is just an empty hair follicle. Then you can as well as see black dots, and this one usually represents the residual hairs that are still remaining, like the one you see here. So that is a black dot. And then you can also see comma-shaped hairs, or what we call the cadaverized hairs, and these are usually bent and distorted hairs. How can let me look for one here, like this one, exactly, like this one, that is a cadaverized hair, and this one is comma. You know how a comma is, like that one there is a comma-shaped hair, even as well as that one here. And then you can also see short vellus hairs. As you can see, that is a vellus hair, that one that is moving like that. Even this one there is a vellus hair. And you can as well see broken hairs, and then also tapered hairs, thinner hairs at the tip, and then also showing early deep growth. Then you can also as well as see white hairs, which we call graying, that commonly also occurs in alopecia areata, as you can see in this picture here. That is graying. You see those white hairs. Then these are yellow dots. Then these are the black dots. So all these are the trichoscopy features of alopecia areata. And when you have all these findings, you can actually make the diagnosis comfortably for alopecia areata. So when you take off histology, we divide it into two. Is it an acute phase or is it chronic? So acute and subacute go together. And in that case, if it is an acute process, you will see normal total number of hairs, and you may get some peribulbar mononuclear cell infiltrate, predominantly around the terminal anagen hairs, and then as well as the catagen hair bulbs. Then occasionally we see exocytosis of inflammatory cells, especially the lymphocytes, and we say that in this case we have the CD8 cells. So we can also get increased number of terminal catagen hairs as well as kerogen hairs, as well as, and then you have increased number of thinned hairs or miniaturized hairs. When you take off this biopsy, this is how it will look like in an acute phase. But in case it is long-standing or it is chronic, so majority of the hairs will be in catagen or kerogen phases with numerous thinned out hairs, which we usually call early arrest, or we usually call them nanogen hairs. And then you will see still an inflammatory infiltrate around the anagen hairs or the catagen hair follicles. So as you can see in this histology picture here, if I magnify, so this is how the kerogen hair usually looks like. So you have an hair exiting like here, and then at the base here you have a new hair being formed. So when you take off your section, you'll find that most of the hairs, like in this case here, almost all of the 4 hairs that you are seeing are existing in kerogen phase. And when you look at the base here, you see this infiltrate of lymphocyte around the hair follicles, as you can see there. So this is an eccrine gland, this is the eccrine gland, this is the hair follicle, another hair follicle here. So this is how the picture will look like in case you are looking at alopecia areata when you've taken off a sample. So how do we treat? So treating alopecia areata is a little bit more, how can I say, more easy to do, because one, you know that the condition will disappear even without treatment. The inflammation goes down, hair regrows. Then 3, we have to understand that you have to screen the patient for any other underlying autoimmune condition, including thyroid disease, diabetes, including SLE. So you take off biopsy, and you can also do blood work where you do an thyroid function test, then you can do the ANCA and all those other autoimmune panel. Then, in terms of treatment, after counseling the patient about the condition, you can now go ahead and give your topical treatment. Either you can do intralesional corticosteroids, that is triamcinolone. This can be given maybe once every 4 to 8 weeks. Or you can do topical minoxidil to try and irritate the area and stimulate hair growth. You can as well do anthraline, where you do a 0.5 to 1% cream. This is applied maybe daily. You can also do combination therapy, where you give your minoxidil as well as anthraline, or you can do your steroid as well as your minoxidil. But in case it is severe, you can actually give high-dose systemic corticosteroids. And in this case, you can also give a monthly intralesional triamcinolone injection. This can be even as you taper the dose for oral prednisolone. So you can get relapse even up to 50% of the patient when you reduce the dose of the steroid. Then you can also give topical immunotherapy, where you can give things like the squaric acid, or you can give the diphenhydramine acid. And in this case, it is not yet, though these drugs are not yet approved by FDA, but they can also be used as alternative. Other drugs you can give oral, the JAK or STAT inhibitors, including things like tofacitinib. This can also promote hair regrowth. So these treatment options, depending on where you're located and the availability of the drugs, you can choose from those. So when it comes to management, if someone has involvement of the eyebrows, these are a little bit hard, and the eyelashes, you need to give intralesional injections of triamcinolone. And in this case, if it fails, then you do other things that can make the patient look better, like cosmetics. You tell them to put on sunglasses, try and hide, things like that, wigs, and as well as group therapy to try and show them that they're not the only ones having the problem. So other things like Xyma laser has also been used in an attempt to treat and irritate the skin and allow hair regrowth. And then other things like systemic cyclosporine has also been tried in some few anecdotal data. So then that was alopecia areata. So this is a bonus slide where we are going to look at other causes of non-scarring alopecia. And in this case, we can have things like pressure-induced alopecia. And in pressure-induced alopecia, this one can occur in patients who have been operated, and then they make the patient to sleep supine with the scalp facing down. So that means that the chronic weight that is in that area damages the hair follicles in that area, resulting into hair loss. And this one, once you remove the pressure, the hair usually grows back without any problem. So that is a pressure-induced alopecia. So still they'll have this oval shaped patch of hair loss on the occiput, and regrowth typically resolves with full regrowth through, though some patients can get permanent hair loss, but it is hard. Most of them, after they have gotten better discharge, the hair comes back without any problem. So it can also be seen in newborns, especially those ones that you make to sleep in one particular maybe facing a particular direction, maybe with back down for long periods of time, no turning, or if the patient is debilitated and sick on oxygen therapy, phototherapy, and the rest for a very long period of time, they can also end up with this pressure-induced alopecia. So when you do pathology for this particular type, we see that you'll have vesicular thrombosis or blood clots within vessels that supply the hairs, and then this can also be seen with together with inflammation detectable within the dermis and then the superficial fat. Sometimes you can see areas of necrosis within the epidermis and around the eccrine coil that can occur in severe cases. So in conjunction with alopecia, so in these patients, you also get synchronized conversion of most of or sometimes even all of the terminal hairs to catagen, then telogen, actually without miniaturization. So they lose their hair when it is still the normal terminal telogen hair. So when you do investigation, you can see pigment cast, you can see incontinent pigment with collapsed lip teeth, that is together with pachyomalacia, uh, that is distorted hair anatomy within the areas that are affected. That is when you take off a sample and you examine under histology. So in the picture here, this is how it will look like. So the pressure was applied on this area, and that's the area that was affected. And you see that all the hairs are lost here. They're still in telogen phase. And this is how it will look like. And then you can also see these thrombosed blood vessels when you do trichoscopy, as opposed to what we see when it is alopecia areata. So in this case, even in this particular picture here, you see this background of erythema that we usually don't see in alopecia areata. So another additional slide, this is what we call the temporal triangular alopecia, also called the congenital triangular alopecia. So this one usually is present at birth, and or it can manifest within the first 10 years of life. It's a little bit rare and commonly seen in childhood, and it will appear as lacent-shaped or triangular-shaped patch of hair loss, which may be a few centimeters in width, typically unilateral, but in some cases it can be bilateral, affecting both sides here, and then as well as this area. So when you do trichoscopy or histology, you'll just see a fine vessels in that area, but you won't see any sign of any inflammation. And this persists for life with no normal natural hair regrowth in that area. So, but currently we have a lot of modalities that can help with this. In case the patient is bothered, you can do hair transplant, and you can also do scalp reduction. In this case, you just cut off this redundant area and then fix the scalp. In one or the other, the patient will be fine. And that will also help correct the wrinkling as well. So the other last one is what we call the lipedematous alopecia, also called lipedematous scalp. This was first described by Coxey in as a type of hair loss, and for him, he just looked at the boggy scalp with a lot of fat, and this was also associated with hair loss. So that entity commonly could affect women who had a higher Fitzpatrick skin type, that is 4, 5, and 6, And in this case, it was thought to also coexist with other areas like central vertex hair loss. Also, there's a potential link to other things like the centrifugal cicatricial alopecia has also been linked to the lipedematous alopecia. And then in the pathology, when you take off a sample, the clear indication that you see, all the clear feature that you see is thickening of the subcutaneous fat layer. Sometimes this can be accompanied by fibrosis that replaces the hair follicles. And then when you see that thick adipose layer, possibly with a little bit of fibrous tracts running through the fat layer. And most of the time, you will see no inflammation. And the management in this case, it is more of surgical in case it is a small area that is affected, but if it is generalized, you may do little or actually nothing. And it can also vary. In some cases, there is little or no alopecia. And in that case, if there is no alopecia, it is called the lipedematous scalp. But if it has alopecia, that's when you call it lipedematous alopecia. So this is how it will look like in the picture. So, and I think we've seen people having little hair, sparse hair, but when you look at the scalp, it looks a little bit boggy and soft. So that is having a lot of fat just below the scalp. And then this is how it looks like on histology. And then you see in the histology, all this layer is fat. So this is compact fat, and even this side that is fat. So this is how it looks like on histology, no sign of any inflammation. And then also reduced number of hairs. As you can see in this side, just a few hair follicles can be actually seen. So that is the lipedematous alopecia, or sometimes the variant we call lipedematous scalp if it's not associated with hair loss. Then the other thing that can cause non-scarring type of hair loss is psoriasis of the scalp, and then also human process factor alpha inhibitors. That can also give you a psoriasis form type of alopecia. And in this case, it is more common than expected. And oftentimes, someone will get that well circumscribed area of hair loss, that's about 70%. And then it can also be diffuse, that contributes to the remaining 25%. And the key features in this case will have hair loss in tufts as you are removing the psoriatic plaque. So as you remove the plaque, you remove a lot of hairs going together with the plaque. Scarring is a little bit rare, but sometimes it can also occur. And in that case, if someone has very thick psoriatic plaques, when you remove them, and maybe if you damage the lower layers, you can end up with scarring. But oftentimes it is then a non-scarring type. And then the tumor necrosis factor inhibitor-induced alopecia still give you that psoriasis type of scalp alopecia, and it is observed in patients who have been started on drugs like infliximab or adalimumab. And this can either occur with or without prior psoriasis in their history. So, and what you have to remember, this type of hair loss has also a potential risk of becoming a scarring type. So it can either be cicatricial or non-cicatricial. And when you do histology, you'll find, depending on the cause, if it is psoriasis being the cause, you see a psoriasis pattern just below, accompanied with reduced hairs and with inflammatory cells infiltrating the biopsy. So depending on the severity, you can now decide your treatment. So if it is psoriasis, you give the psoriasis, the hair will come back. And if it's the drug, you stop the drug and the hair will come back. Then another one, as we conclude, is what we call the congenital atresia with the papules. So this is one of the conditions that's a little bit rare, but actually someone, I think in your entire life, you have seen someone with this type of alopecia. Usually, these patients starting from way behind when they're still young, they don't actually have hair. But instead of where the hair follicles were, they end up developing monomorphic papules. So in this case, they usually don't have hair. There is no regrowth of hair after losing it at birth. So it has been associated so it is associated with follicular cyst like lesions that appear later on in life. So after the child shedding off the lanugo hair, they actually don't develop the subsequent type of hair. The terminal hairs that they're supposed to develop, but instead they first be bald. After that, later on, then they develop these papules. So it has been linked to a mutation in two genes. The first one is what we call the hairless gene that sits on chromosome 8, loci 21, and then the other gene that has been associated with this type of congenital atresia is what we call the vitamin D receptor gene that sits on chromosome number 12, loci 12. So those two genes are the ones that have been associated with this type of hair loss, and in this case, still it is also a non-scarring type. So it has also been associated with other disorders, especially the vitamin D dependent rickets, due to the mutation in the vitamin D receptor gene. You know, vitamin D is very important for growth of the and development of bones as well as the teeth. So someone who has a defect in the vitamin D receptor gene, they end up with a defect in the receptor, so meaning that they cannot respond to the orders from the vitamin D hormone. So the inheritance pattern of this condition is not yet known. But what we know is that someone has defect in these two genes, the hairless gene and then the vitamin D receptor gene. So this is how they look like. And I think you've seen people having scalps. You see now, instead of having hair, they end up with papules. So the same thing that you see here, this child lost hair, and then they end up with this particular papules. So that marks the end of this session. But remember to subscribe, share with your colleague, and then put a comment. That helps us to push this information to more people, and that helps us to educate